Okay, this is a question for Dr. Henry. You mentioned there was some kind of security system for smartphones if you want to transmit an EKG or an image to a consultant. Could you explain that?
Yeah, some of the hospitals have issued their consultants, and they pay for it or whatever it is, a phone that they're not supposed to be using anything on except hospital business. And then they have to download their phones and that sort of thing. In at least some way, they've got a secured map or direction. And they're not supposed to be sending things out to their best friends, anything like that. One use, and that's to give an opinion back to the hospital, either the emergency department or the ICU.
So there's also an attachment now to a Panoptic where you're looking at someone's retina and it doesn't, and if you're like me, you look in the retina and you go, I don't know what the hell that is. It's not normal. And that you can attach your iPhone to that, and then you can send that to an ophthalmologist. You can use this. Our derm service frequently accepts images from the ED to just talk about, give some ideas. And now lately, one of the things, I don't know how many of you work in a teaching institution or if you work where you may be presenting to other people, nowadays, although it makes a lot of the administrators nervous, a lot of times the resident comes to me, I got this 50-year-old diabetic with a rash, it involves the bottom of their foot, and there's an ulcer, here's what it looks like. It's like great, now I don't have to go over there. So this is an issue that is coming up in hospitals really, really quickly, and they're nervous about it. Admin is nervous.
Technology is way ahead of the law.
Yeah, what you need to realize is CMS requires that if you're going to be transmitting any data, use encryption software. They do mention, I think, a couple of vendors potentially in the CMS website. I don't recall any of them, but that's the buzzword. You need encryption software. It shouldn't be on a personal cell phone. I mean, it really should not. It should be, as Greg said, it should be something, a device that's the hospital owns. Let it be their liability. And let it be their issue, but it needs to be properly encrypted to protect the protected health information that's being transmitted.
A lot of us are very casual, too, about taking pictures that we're going to show at rounds, we're going to do various other places. All the things that you do for release of information, you do with those things, so that you actually have a file. You can say, oh no, Mrs. Smith said we could take Johnny's picture. Here's the written data on that. And again, it ought to be protected material. Because you have a release doesn't mean it's a release to send to your BFFs. This is for medical purposes only, and people have been getting real upset about that.
If you're taking a picture of a patient, you need to get their consent just like you always did if you wanted to use a regular camera to take their picture. If you're taking a picture of their ECG or their X-ray, you don't need their consent, but you need authorization potentially to transmit that elsewhere for an unintended or unauthorized disclosure of protected health information. So be a little bit careful. One thing that I've always said, we've had this conversation, is if you're interested in sending ECGs to the cardiologist, just pick a really good STEMI and keep that one on your phone and take out all the identifiers. Just keep sending that one to the cardiologist. They'll just keep coming in. Then you don't have to worry about it.
Right, exactly.
The other thing about the pictures is be careful who's in the background. Because sometimes it's the background person that gets you in EMTALA trouble, not the person you're actually taking the photograph of. So do your best to take everyone out of the background.
I've not seen much medical photobombing. I've not.
Yeah, the other sticky wicket is when the patient's family wants to film you doing the procedure or something. So that's another sticky wicket that is coming up that I haven't seen really well addressed. We all are wanting to have the family members in there and shared decision-making, et cetera, but now they're also photoing and filming in the room. So this is an area where I don't think it's been comprehensively dealt with. We recently had a cop get in trouble. They were there with a patient that they brought in. We were looking at stuff on the PACS, and he had a particularly dramatic image on the PACS related to the law enforcement techniques, and they were all laughing and taking photos of it, and the hospital administrator had a cow, and they got complaints written to the watch commander, et cetera.
The only way to deal with it is really just have a hospital policy that says, listen, no one's allowed to take any video or that type of thing in the department. You can always say it's they. They never ask who they is. They understand it's not you. That's the key. So if you say, no, I don't want you videoing somebody doing a procedure that I'm doing, then you're having an argument with the patient or the family. You say, listen, they just don't let us do that.
Just tell them Kevin Clower prohibits it.
That's perfect. That might work.
You know, I think it's only fair, too, though, that a nice sign be put up that says something like, for your privacy and the privacy of our other patients, there is no photography permitted in the emergency department. So you give them a heads up so that you don't embarrass them when they inadvertently take a picture that they ought not take.
I had that case where the young boy had come into the department. He fell off the back of his grandfather's tractor and went through an industrial brush hog. Somebody else in the department has got their kid in there for fever, whatever it is. This guy is over there taking pictures of this kid and sending him off. Now, the father of this kid sees this guy and smacks his ass. I agree with that, but unfortunately, it started a problem in the department, and we had to rethink what we're going to let people do, because you know what? He had no business to be taking pictures of that kid, not his, in the department.
All right, let's go over here on the left microphone. Step up and speak up.
All right, this question's for Dr. Birnbauer. I'd just kind of like you to weigh in on the pros and cons of tramadol in the pain armatorium.
I dodged that one.
Are there any?
I really thought if I didn't mention it.
Were there any pros?
There are no pros.
So tramadol is sort of the default go-to. It's not that it's a pain medicine, but it doesn't cause that much trouble, and we can give it to the old people and all the people that were worried otherwise. It turns out that head-to-head, when it's tested, tramadol in these placebo-controlled trials, which are really important to see if it really works. In placebo-controlled trials, it is no better than acetaminophen, and in fact,
It's worse.
Ultram became Ultracet with acetaminophen when the study said that that's what works. So they added it to their own drug. The problem with this is that for some patients, drugs work individually. You have to kind of gauge that. But overall, the side effects are pretty significant. In older people, they're really significant. They get crazy. And in overdoses, it's a nightmare.
So
They sneeze
tramadol-
and they stop breathing. It's awful.
I don't know with the rest of the panel, but I basically not giving out the drug. I know I get some people who did ask for it. Bottom line is, if you look at all the data, it's hard to defend using that medication for what it gives you. I just think you ought to just wipe it off the map. As far as you're
I'm
concerned.
It's
so
awkward.
excited
Yeah,
when someone actually does ask for it. That's such a rare event that I go ahead and write for it then. Tramadol works for me. Can I get a prescription of tramadol? I'm like,
If it works for them and they tolerate, fine. But the literature's pretty clear. It's a terrible pain med in terms of its efficacy, and it's as bad or worse than codeine in terms of side effects in someone who's novel to it. In terms of its being non-addicting, sorry, that's not true. So tramadol sort of is a drug that never need to be invented, and while it certainly captured people's imagination and the marketing for it was great, it's really hard, other than a patient that says, I'm on it and I really like it, other than that argument, it's hard to invoke a reason to prescribe it de novo.
As you can see, the big fans of tramadol up here, and Ultram as well. The big fans of Ultram.
We love overdose, it's nasty.
It's horrible overdose.
By the way, if you want to be the next billionaire in the country, if you come up with something that works, low side effects, non-addictive, let me know and we'll both market.
How about Darvon?
Oh my God.
Okay, let's go over here on the right.
Why does OxyContin not contain Tylenol?
Because Tylenol overdose is lethal. So what happened was so many people, one of the big disasters that was going on out there for a while was someone would come in, look like a narcotic overdose, pinpoint pupils, they get Narcan. They would say to me the traditional pleasantries, something along the line of honky punk motherfucker, and then they would leave. The problem with that is their opiates reversed, but if you took enough of Vicodin, for example, to have that opiate overdose picture, you're probably over your 7 grams or 8 grams for the Tylenol. So it really is wise to pull it out.
Yeah, it's marketed so that you don't have the Tylenol aspect of the drug. You just get the opioid.
But doesn't that also lead to injection and snorting and abuse?
Sure enough.
Yeah.
Sure enough.
But I'll tell you.
Called hillbilly
they'll
heroin
inject
for a
and
reason.
snort and abuse anything. I mean, anything.
yeah, if Tylenol was included in it, I don't think that would stop that abuse potential at all. I don't think they would. I think, oh God, that could be dangerous. And now we can do IV acetaminophen, so it's probably okay.
All right, let's go over on the left microphone here.
Two questions, please. My first question has to do with the transfer of a patient. In our department, a lot of our pediatric procedural patients that need supracondylar fractures, appendicitis, we transfer to another hospital close to us. There is push in our department to let some of these kids go by POV, by private auto. There have been some stories that their insurance squawked at paying and things like that. And there's some people in power in our department that are pushing for this also. My view is that, and sometimes not sometimes, almost all the time, these kids have already gotten analgesics on board and they have IVs in them and what have you. And my view is that I'm responsible for this kid until he gets to the other hospital. Just wonder what my medical legal exposure is there.
Well, I think if you ever choose a treatment or a mode of transportation that's not safe, you do have exposure for liability. From an EMTALA standpoint, the transferring facility is tasked with choosing the mode of transportation. Certainly you want to make the other end happy too, but it is your choice to decide whether it's helicopter, whether it's ambulance, or whether it's private vehicle. And there's a big misconception out there too that people think if you're transferring from one hospital to another, it has to be in an ambulance, otherwise that's an EMTALA violation. No, EMTALA is silent on the mode of transportation except stating who has to decide how they're going to be transferred.
And you have to really be careful about covering your ass. Do you know what it costs for an ambulance to take you like a quarter of a mile? I mean, they're going to put a paper sheet on you, give you oxygen that you don't need anyway, and this bill's going to be $800 or $900. And
No, it's not. It's going to be $2,000.
we had a great case come up where a finger was transferred to Diane's hospital.
Yeah, I sent this question out to all of these guys because it came to our place.
So a transfer was made to her hospital.
70 miles by ambulance for a finger injury. 70 miles.
And there are some hospital systems, in fact, that was one of the ones that we dealt with in a product that we do called Risk Management Monthly, where the system basically says every transfer will be done by ambulance. And that is just unreasonable, unfair, and it's unfair to the payers, and it's medically inappropriate in a lot of cases. And that's just, you should really try to fight that.
Now, on the flip side, if they recently had procedural sedation done and things like that, and you're worried about their vital signs, I'm not sending that by private auto. And I also would add that when people are transferred by private auto, be really clear when you're involved in these transfers, is it discharge and referral, or is it transfer? So, and private auto doesn't make it one or the other. You can transfer by private auto. You could also discharge and refer by private auto. And a lot of people are confused by that. And so when someone leaves another emergency room and comes straight to my emergency room and they want to call it a discharge and referral, I'm like, no, that's really a transfer. That ought to have been, we ought to have had a chance to discuss that with the way we do other transfers.
But there's transfers and there's EMTALA transfers. And EMTALA transfers basically deal with unstable patients. So these patients who've got their fingers splinted are stable patients, and once they're stable, EMTALA is not operating.
Yeah, I want to be very careful with that, though, because stable is not the term that you and I understand. Some people say that, and certainly the law said this, that with an appendix, you know how you stabilize an appendix? Take it out. And so just be careful about the term stabilize, because it's not what you and I might use as the phrase.
Right, and going back to what Billy said too, a discharge to follow up. Now, the federal government is not silent on this in the EMTALA statute. You can't discharge somebody to get their definitive care somewhere else unless that person has special expertise and equipment that isn't available at the hospital. A good example is either ENT or ophtho. Ophtho we discharge and you get their definitive management in the office. But if you, just like Billy said, you discharge and tell them, we'll go to the county hospital down the road and get your care there, that is an EMTALA violation. So you have to be really careful with that.
I think the part of the problem is that the higher level of care is the issue, not the unstable patient needing a cath because they need a balloon pump. It's the distal tip amputation. We don't have an orthopedist that will take care of this. So it's a higher level of care, but that's not an unstable injury by any means.
And Greg is right. He says, it has nothing to do with stability. What you have to do is perform the medical screening examination, which includes stabilizing your patient to the ability of your hospital, yourself, and the resources of the hospital. So, quick example, if you're a level 3 trauma center and you have somebody with a liver lac, you may actually have to do a laparotomy, pack the liver, keep them open before you can go ahead and send them, because that's as stable as you can make them.
By the way, we did have a case where a young boy was in with 9 or 10 with a torsion of a testicle. Smaller rural hospital. The town's ambulance is out on another run. So it would have been an hour and a half till they were able to come to the hospital to take the kid to the university center. The emergency doc just said, yeah, get in the car and go. And I think that was the perfectly correct thing to do.
Although you have to be careful that the people don't get lost on the way to the hospital that they were being sent to, because although I've heard of a case, I don't think it went anywhere, but they went to the wrong hospital.
Yeah, that could happen. One thing you have to remember, if you're going to send somebody in their private vehicle, you still have to fill out all the EMTALA paperwork and send them the packet of paperwork. You don't fill out the ambulance verification form so that they can bill the ambulance company. That's the only form you don't need to fill out. But the packet of paper still goes with them.
Records, images, the whole thing.
Yeah.
My second question had to do with Dr. Birnbaum concerning analgesia. I'm a fan of the MAD device, the
Spray?
nasal. We use that in EMS. It works great, and I just want to give a shout out to that for the audience. I think it's an awesome device that we ought to be using more in our departments.
What he's referring to is it's basically a nebulizer. It's a syringe with a little mister on the end that you can give intranasal fentanyl, for instance. And even out in triage, get people's pain under. We're using it now in our peds department routinely for kids with painful conditions. So the intranasal sort of administration is becoming more and more something and it's nice because you can do it quickly, you don't need a line, it works quite well.
I think
and it's important because when you injected it up the nose, the old days, just putting a syringe up there, it was pretty clearly shown the kids just swallowed it. You weren't taking advantage of the absorptive area inside the nose. The mister really gets it there. We're using it at our place.
LA County, hook, line, and sinker bought it across the way.
I think it's an atomizer device. And actually, an interesting fun fact, the guy who developed it's in Salt Lake City, still practicing clinically.
All right, let's go over here to the right microphone.
Mine's just kind of a comment, I guess, because we definitely practice in different areas, because I'm very rural out in Montana and Idaho. But a couple of things. One on the EMTALA thing. Like I've had a patient before. Sometimes we have to do double duty. We'll be in the clinic in the morning and yet covering the ER at the same time. And I've literally seen a person out in the lobby running around with the kid. And I have 12 patients in the clinic, and they're not being seen fast enough. So they walk around the building, come in the other door, and go into the ER. And I didn't rush over there right away to see him because the nurse called me and told me what was going on. Now, I mean, is that supposedly something ethically or legally wrong there? I mean, I know there's a time limit on it. And then the other thing is, when you mentioned something about the door to patient time, it takes on a little different meaning in rural Montana when you've been on all day and they call you at 2 and the same person is back with a toothache that you've seen 3 times before in the last 2 weeks, and it seems like they're always allergic to all anti-inflammatories.
Isn't that a coincidence?
You got them there too, or?
No, we never heard that. No.
We don't really have those problems.
You know, your patient who went around the corner from the clinic and then went to the ED, the tough thing is the black and white answer for you is when they present to the emergency department with an emergency medical condition, you're obligated to do a timely medical screening examination. So if you think that person, you know, doesn't need it, or you make some sort of judgment call, particularly if you're wrong, there's going to be a real problem. Have they gamed the system? Yeah, they are some of your smartest patients of the day if they knew what to do and went over there. But they put themselves in a different situation. And what's unfortunate for you in the circumstances that you're involved in and the situation you're working in your rural environment and covering 2 roles is CMS doesn't care. It's not a state statute. This is a federal statute, and it's applied evenly across every emergency department across the country. So if you want special dispensation because you work differently, they're not going to provide it if somebody makes a claim or files a complaint. And so just be careful.
Okay, over here on the left.
Yes, I also practice hospitalists and ER in rural areas. And my question has to do with pain management and medical legal issues. Drug seekers. I I briefly
We send them all
saw.
to the rural area from the urban area.
We have a bus that goes right to your clinic.
Yep.
I briefly saw a excerpt email signed by an ER doc in a rural hospital up in Potsdam, North Country, and I forgot to get a copy of it. But it talked about the ER saying the ER doctor, how tired he was in these issues, and he kind of just gave the patient the reality check. Hey, you're not getting it. And then I had another second part question having to do with when you come across a social history that concerns you in the safety of the remaining community population.
Well, the two-part question, obviously. The first one is, I've never lectured anywhere where they didn't think they had a disproportionately high number of drug seekers. It doesn't matter where you are. There is that percentage of the population who show up, and God sent them to test your patience. And I'm serious, because we all see them, and you have to adopt a certain attitude about this, that I'm going to take a deep breath, walk in, I'm going to say, you do have pain. This is what we're going to do. Now, I don't think, and of course, you've done a MAPS check. You know, you can check the 3 states around. This is their 42nd visit, you know, for pain medicine, something like that.
Well, those things have really helped now. I think we have cures in California. It really makes a difference when I can say, listen, you've had 30 prescriptions in the last from 5 different hospitals.
I'm worried about
There's a
your
problem.
safety.
We're not doing it today.
Well,
That
we're not
helps.
doing that, but that doesn't mean I don't try other things.
Yep.
And talk about other modes of taking care of the pain. I kill them with kindness. Now, eventually they figure out they're not getting Percodan, but that doesn't mean I'm not going to talk to them about their pain, because that's what really makes them unhappy. And by the way, people with chronic pain problems, if you don't think they can't have a hidden disease, you know, when I see chronic pain and I notice a temperature, I just sort of think about it for a second. Because guys who are willing to stick things in their arms and shoot things in there, they get abscesses. And you've got to do it right each time.
But think about chronic pain, addiction, pseudo-addiction. All of these things fall under the category of mental health problems. And it worries me when I hear providers in emergency medicine who say they're the safety net of the healthcare system want to select out one group of patients and say, I'm going to be here for you, but not for you. I've decided you do not belong in my emergency department. Now, I'm fine if you say, listen, I'm willing to do X, Y, and Z, but what you're asking me to do is unsafe for you. I'm uncomfortable personally doing it, and I think you may have an addiction problem, so I won't write for that. But tell me how else I can help you. That's a very reasonable approach, trying to address a patient's concerns within a comfort zone that you've developed clinically. But to just say, I don't want you here, I don't know why you're here, put up a sign in your emergency department that says, by the way, before you even talk to the doctor, understand they'll do nothing for you, that's an embarrassment to emergency medicine as far as I'm concerned.
Actually, there was a recent case where the emergency department put in their lobby their policy with regards to the issuing of pain medication. That was viewed as an EMTALA in violation because you're not supposed to discourage patients from getting a medical screening exam.
Well, what happened was actually the whole state of South Carolina wanted to do this. The South Carolina Hospital Association band together and said, in our treatment areas and in our waiting rooms and our emergency departments, we are thinking about putting a sign up. They had the presence of mind to send this to their regional CMS medical director, their carrier, and said, what do you think about this? Well, I've got a copy of the letter that he returned to them, and it is very, very clear. Anything that dissuades a patient from getting a medical screening examination is, without a doubt, without discussion, an EMTALA violation. So you need to talk to the people. If you want to do their medical screening examination, say, I'm not going to provide any further care, be nice and send them on their way. But anything that tells them they shouldn't be there in the first place and dissuades them, either intentionally or unintentionally, and has them move away from getting care is considered an EMTALA violation.
The reason I worry about the drug seeker mentality is that there are 2 victims here. That person, because they have a very sad life if that's all they're dealing with is getting drugs, and you, the doctor, because I think this sort of tug of war actually is what grinds us down in emergency medicine. Nobody in this room ever got a sort of, this low-level anxiety, anger, that sort of thing, from seeing great cases. It's this constant sort of wearing at you that really does it. That's why I think you have to adopt an attitude that I'm going to try something, but I'm not going to take this loss or disappointment that personally, because if you do, I think it ruins your career over a period of time.
Yeah. Casting judgment, casting blame on people doesn't really help you, like Greg said. I think it just makes us angry and burn out people.
Yeah.
But I tell you, what's really amazing to me is that we can't address people in a way that removes our emotions from this process and just try and find out what we can do to help them. Let them know there are certain limitations. Again, this is an opportunity to say they. I've said, you've probably heard that they don't want us prescribing certain medicines, and what you've requested is on they's list. I can't provide that. So, I think you just really have to see what services you can provide and make sure it's well known up front and do what you can. It's
pretty clear that a lot of the burned out physicians that I've met over time had a disproportionate concern about pain management issues and being taken advantage of, and here's another pain seeker. And I think that, they're right. You have a long career to protect. You have a 30-year career in emergency medicine, and if you let it be destroyed prematurely because you take this issue on pain management too personally, that's not a good thing to do. And as Greg said, you just basically got to get your happy face on, get the routine down on how you handle these cases, and do not take it personally, or it will help destroy you.
Remember, it's not a choice. They had nowhere else to go. Or else they wouldn't sit in your waiting room for 2 or 3 hours, being the last one to triage, have everyone look at them saying they're back again, sit in the room, watching people talk about who has to take that chart, till they finally come in and maybe they get 3 to 5, at the most maybe 10 of whatever. And for those of us in this room who think someone's going to commit 5 or 6 or 7 hours to go and sell 5 to 10 Percocet, they're not making a living doing that. That's not a good business model.
And the other issue is there is this subset of people who do have chronic pain, who are genuine and who have worn out all their options, kind of thing, and they're coming to you as a last resort. And you would not. It would be better to overtreat 5 drug addicts than to not treat one patient who has genuine pain.
And in the papers, the scientific look at what happens when you have a cures program or something like that, the database, it was interesting. A couple of papers in the abstracts have said that when people did it and they queried it on a fairly routine basis, what they found was that the amount of narcotics prescribed went up.
Right.
Because they actually were able to verify a substantial number of people who had pushed their buttons, who actually were in a pain management clinic, who actually did have this documented entity, who'd had the EMGs. They were able to find stuff out about them. They were like, oh, all right, fine.
Whenever you're whipping yourself with the hair shirt, understand this: by withholding a drug, you never, ever cured an addict. By giving a drug that one time, you never created an addict. And I think sometimes we pull more of this on our back than we really need to. You're a moment in what is a whole lifetime situation for these people. You're not to blame for anything. By the way, there was this weekend on TV some other fool who said, well, they go to emergency departments and get pain medicine. If you look at what we do, we prescribe, most ER docs, like 10 tablets, 6 tablets. We are responsible for about 3% of the pain medicine in the United States. The rest are family practitioners, internists, that sort of thing. You are not the problem in this country.
No, what's interesting, you look at when they first said we were the source of most prescriptions, they were right. When they looked at prescriptions, volume of prescriptions written.
Right.
When you look at volume of drug, actually the number that I saw, a little different than Greg's, this is from the FDA, is 4.7% of short-acting opioids come from the emergency department. So clearly we are not the source.
All right, let's go over to the right microphone here.
Thank you. The emergency department in which I currently work has recently instituted callbacks for patients who were seen probably the day before, and they've requested that providers do a certain number. There's a lot of discussion in the department right now about this. Is there medical legal exposure with that communication? Should it be documented in the medical record? We're encouraged to leave a message if the patient is not at home. Is that a HIPAA violation?
Wow.
Number one, is everybody going to get called back?
No.
How do you decide who gets called back?
Serendipity.
Serendipity, exactly. I've seen the case where they ask that exact question in deposition. So, doctor, you people call some people back. Is the reason you didn't call back my person is you didn't like them? You didn't think they deserved what everybody else got?
Oh, no, they had a bad paramix. Sorry.
Yeah. The point is, why are you doing the callback? Is this theatrical? Is this a quality survey? I don't know why, but just be careful. Because if people really need to be seen back, it shouldn't be serendipitous. They ought to come back and be rechecked. You know, that the phone is a dangerous
a
weapon.
press gainy kind of thing? This is we're lovely people?
It's a Studer initiative. We've just gone through a patient satisfaction.
Right. So the way you
attempt.
do that is you call everyone and you start the conversation with, did you like the excellent care you received in our ER yesterday? Yes. Thank you. Click. You're done. You've done what you need to do with it. Because seriously, otherwise you're adding the medical aspect of it that puts you at medical legal risk.
I may be the only one who believes these are a good idea up here, but I really do.
No, I believe they're a good
I
idea.
think it's great.
I think some of them are a good idea, too.
It depends on what.
Yeah, we've implemented this at every one of our sites. We've gotten to the point where we aren't even waiting for the hospital to do it. We're paying for it.
Who do you call?
Well, we do is we let the hospital and our medical director at our site decide. We want a plan, though. There has to be a policy. You have to follow it. Is it 10% per day? That's fine. If it's 10% random, fine. Follow the policy. Do you select cases like chest pains that went home, abdominal pains, and peds fevers, high-risk entities? That's fine. Just follow your policy. Some of our departments call 100% back. And the thing is, it shouldn't be just about patient satisfaction. We find, because we're self-insured, we have our risk retention group, that this is a huge risk management tool. It is also just plain good quality medical care. When you talk to people
if you have the ability to follow up on what you're calling them about.
You do, and hopefully you do. So you talk to them and you say, you know, and whoever's making the calls for you, and that has to be defined also, do they need to come back? Then you tell them to come back. Do you understand? We have standard questions we want to ask. Do you understand your discharge instructions? Did you get your medicines? Did you get follow-up? If those three things haven't happened, we're going to try and plug them into resources that will do that. And that's a very valuable thing. Does it expose you? It exposes you if you don't identify somebody who needs your help. It exposes you if you don't document it in the record, and they talk about an interaction that is inaccurate and it doesn't really reflect what really happens. So you've got to document it. You have to have structure around it.
So
Don't
I think you have to
practice
document.
medicine on the phone.
Yeah.
Don't practice medicine on the phone.
And I wouldn't leave the message, you know, did you get your HIV followed up? You know, probably not the, you know, so I think you want to verify who you're talking to. I wouldn't leave messages, personally.
No, we do leave messages, but we do is say this
But not
is
medical
so-and-so
message.
on behalf of Dr. Klauer calling just to check in on you about your care the other day at such a facility.
Yeah, that's fine.
Yeah,
But I wouldn't
nothing-
leave any medical information on a message.
No, culture results, no.
Thank you.
Okay, let's go over here to the left.
I have a question about transferring patients and the communication between the referring clinician and the receiving facility. So, you know, I think I'm more often not working in the emergency room and transferring somebody to the emergency room, say from an urgent care center. If you, in that setting, often in the past, I would speak to the physician. I often calls, can I speak to the doctor, talk to the doctor about the patient transferring. Increasingly, I'm finding that I'm finding a nurse protocol. So the nurse, the triage nurse or something from the emergency room will accept that patient in the name of a physician there. Can you comment on sort of the advisability of trying to actually speak to a clinician at the other end, or is it okay for sort of say, okay, well, you've talked to the nurse at that facility who's accepted it for.
Yeah, I think there are two issues here. Good quality of care we've talked about. You want to make sure you speak to somebody, make sure you know what your expectations are. You're going to send them in, make sure that they have room and capacity, whatever it is. It'd be great if you could talk to the right person, whoever that is. And maybe it is an intake nurse, maybe it is the physician. But if you're at an urgent care center, you're not subject to EMTALA.
Yeah, that's the first
so
thing.
if you want to send them, you should try and do the right thing for the patient. But if you send them and they show up there, I'm not advocating this because it's not a good idea. But it's not like you violated that statute because you're in a Type B emergency department, not a Type A emergency department based on CMS's definitions. So you're not governed by that statute.
But there are things that would be viewed as professional courtesy that you've all been in places in emergency departments where somebody shows up and you didn't get a call and you have no idea what's going on. and it just makes you annoyed. So the idea of actually trying to talk to the doctor who's going to take care of that person is perfectly reasonable. And I think the idea of having you blocked by a nurse is, you know, I think you should just end run them and say, listen, I'd like to speak to the doctor.
Well, one thing we do at one of the places that I work at, there's an urgent care center close by, and they don't have many resources, and they refer to us frequently. Well, the nurse takes the call, unless they really have to speak to us about something. They just take down what the issue is and the patient's name so we know when that person gets here, oh, you were just seen at that urgent care center. And we're not, believe me, they don't want us to send them back. They don't want a phone call most of the time. So as long as we know, and that's our policy, and we follow it, the intake process is fine.
By the way, if you're on the receiving end of this, and I've heard this 1,000 times, well, nobody called us. What the hell are you doing here? This sort of thing. You know what? It's almost never the patient's fault that the system didn't work. But the only person we've got next to us who we can beat up about this is the poor patient. So whenever you feel that there's been a discourtesy here, that you haven't been informed, you know, you might want to call up, speak to their chief about this in a dispassionate, you know, take a deep breath, let your anger go down, talk about it the next day, but don't beat up the patient on these issues, and I've seen it 1,000 times.
And personally, when it is an EMTALO transfer, higher level of care, facility to facility, I like that conversation to be doctor to doctor.
Right.
Period.
Very good. Let's go to the microphone on the right here.
I also have a question about treating pain and medical legal issues. Where I work, I have a lot of patients that are, when they're leaving the ER, they're walking or they're taking public transportation, so not operating a motor vehicle, but not having a person there giving them a ride. How do we treat their pain in the acute setting and then protect ourselves from a medical legal perspective?
So you can still get, so what you're referring to is obviously if you send someone out who's intoxicated or high on the drugs that you gave them and then they crash their car, so that lawsuit's happened a bunch of times, you can't do that. If they're going on their own and no one's taking them home, but using public transit, this is certainly something that happens in my facility, you still got to worry about it, because if they walk out into traffic and get nailed by a bus, you're in the same place you were with the car. So I think it's more about what their capacity is at the time they're leaving when they're going by public. Can they walk? Do they have normal gait, speech, and balance and reasonable judgment? They don't have to have an alcohol level of 0, but they have to have the capacity to function out in the world, and your note should say that at discharge.
Exactly right. You should always make sure that it's a safe discharge. If you feel that someone's not safe to be discharged for whatever reason, medication you provided or their mental status or their social situation, you just don't do it. How many people do you think we see on the roads every day that are taking 2 Percocet every 4 hours? They're okay to drive. It's not like if you gave them something they can't. Now, if you tell someone, you have to deal with this concept, this legal doctrine of duty to the third party. The third party is the person who Billy was talking about. They get in a car and drive away and they hurt somebody else. What is your responsibility to the third party? Your responsibility is to say, hey, I just gave you medicine. You said you have a ride. You can't drive because I just gave you this medicine. You just had a seizure. You can't drive. Now, if they walk out and get in the car, it's well documented, you told them not to, you really have met your obligation there for the most part. It doesn't stop someone from filing a lawsuit, but you met your obligation in most states. But you just have to document that well in the medical record. I always ask the nurses I'm working with, hey, you saw the same thing I did, right? They walked easily, had no trouble, they had no impairment. Please put that in your note, too, if you feel comfortable discharging them. And then you're covered.
It's also one of the reasons why you don't want to routinely obtain alcohol levels. Because if they have tremendous tolerance and they come in, I mean, I got some people who are withdrawing with alcohol levels of 150. They need to have an alcohol level of 300 to function. So getting the alcohol level in some ways can sort of corner you, because we know alcohol metabolism is about 30 an hour. You don't induce metabolism. That's a big myth. You induce tolerance. So, you know, I prefer not to have, if the person's obviously clinically drunk, I don't need a level. It just sort of corners me. If I'd like to be discharging them, you know, 3 hours later and they have normal gait, speech, balance, seem rational, I'd like to be able to do that.
Let me make a comment about getting the number, because I've had cases where the number they got was under the legal limit. Okay, did you also get a Vicodin level at that time? Did you get a this one, or that one? Because you've got a normal alcohol level doesn't mean you're set to go. It's the clinical exam that says, are they okay?
Right. And that number is basically a number about driving a car. It's not about walking out of a building.
Right.
Okay, I think our time's about up. Do you want to hang up here? If we
Can we
have
do one more?
One more. We'll do one more over here on the left. Then.
One more, last one.
Thank you. I actually have two questions.
Oh, under the wire.
Sorry. The first one is, I know Dr. Brummel, you said about Toradol is really good for biliary colic, but what if you have that patient that you give the Toradol to and they're not satisfied? When can you go to the next step, and like what's the, I don't know.
So there's no reason you
protocol?
can't use a opioid at the same time as
No reason.
Toradol.
None,
Okay.
zero.
So, in
So
fact-
if the
in fact,
Toradol doesn't work, step it up.
Right.
Well, you
Right.
can
So
do
you
it-
could even do it together. So
Oh, okay, I
it's a
didn't know that.
standard practice for me, for most of these colicky kind of pain,
Yep.
to give fentanyl and Toradol at the
I
same
do
time.
both.
Oh, okay.
Many
And if
people
10
do it for
minutes from
kidney
now-
stones.
Right, if 10 minutes from now they're back in pain, I know the Toradol didn't work, and now I need to do something different.
Right, right.
I do both on
And then
myself.
My next question was about, because I work with a lot of physicians, I have some physicians that really like Talwin and Stadol,
Oh, dear.
and I didn't hear you talk
Yikes.
about that, so I was kind of
Oh,
curious
dear.
about that.
So
Yeah, you need to get a couple journal subscriptions for that doctor as a Christmas present.
yeah, so the idea of those medicines is you have an antagonist, agonist together.
Right.
Please, really? I mean, either treat the pain or don't. This agonist-antagonist thing, they don't work very well. The side effects are significant. If they're already on a narcotic and you give them one of those, you're going to make them withdraw. It just doesn't, it makes you feel better maybe of what you're doing, but it's not good medicine.
It's pharmacologic soup. I don't like it.
Yeah, and if you try and give then an opiate following those medications,
Gonna work.
they're not going to work.
Right. Okay, thank you.
Exactly.
Exactly.
Very good.